Hello, everybody. So the topic of my PhD is the multimodal analysis of functional connectivity changes in post-stroke patients with disorders of consciousness. My name is Danuta Szirmai, and I'm a neurologist resident in the National Institute of Mental Health, Neurology, and Neurosurgery. These were my projects for this half year I'm going to further talk about. My first project was about assessing the prognostic power of EEG connectivity measures in patients with disorders of consciousness. What are disorders of consciousness? These are on the continuum of consciousness, which stretches from coma until the fully conscious state. These are, for example, the minimally conscious state and the unresponsive wakefulness syndrome. These patients might look wakeful with the eyes open, but they do not show signs of awareness, they do not talk, they do not follow instructions. And we call them chronic or prolonged if it takes more than a month of this disorder of consciousness. They are relatively rare diseases, but as the healthcare improves, more and more patients are being treated. Are you sure that he will not recover? These are the very difficult questions that physicians face when treating these patients. And it's very difficult to answer because we know that 1/4, 1/5 of this patient population can regain consciousness even 1 year after the initial brain injury. And it's very important because unknown prognosis of these patients results in suboptimal treatment and the withdrawal of the treatment, which is crucial because the treatment withdrawal for new complications such as pneumonia or urocystitis can cause the death of these patients in more than half of the cases. So what can be predictive markers in these patient populations? We can use demographic data such as age, etiology, comorbidity. There are some behavioral scales such as the coma recovery scale revised. We could use EEG markers, spectral and connectivity markers, and also neuroimaging techniques. Our aim was to quantify and to compare the prognostic value of the EEG connectivity measures and the always used behavioral scale, which is the coma recovery scale revised. So the clinical question was if EEG connectivity measures could improve the prognostication of these patients with DOC compared to the clinical measure. And we hope that our research would help clinical and rehabilitative decision making and also have communication with the patient's family. We have conducted our systematic search in 2022 November, and we had over 7,000 articles in the beginning, of which only 5 articles were eligible for the final analysis. What were our outcomes? Our outcomes were all diagnostic accuracy measures, which could differentiate recovery and non-recovery patient. I could extract AUC values of EEG connectivity measures and network metrics. We could calculate this of spectral power, of CRSR score, and also of age. And we could calculate the sensitivity and specificity results of the CRSR score. These are my main results of the meta-analysis. It's the diagnostic accuracy of the prediction of recovery. In this plot, the 5 articles are included, and all articles included at least 2 of the following outcomes. The effect measure was the area under curve, which is the discriminative capacity of a given measure. We have talked about it before. And we can see that the AUC of the EEG connectivity measures and network metrics is 78%, which means that it correctly diagnoses 4 out of 5 patients. The AUC of EEG spectral power is a bit lower, but not significantly lower, nor clinical significance there is. It's 74%, while the AUC of clinical scale is 67%. I'm showing at the top of the plot the AUC of automated outcome prediction methods, which is a machine learning algorithm that comprised of connectivity measures that are listed below. And we can see that the discriminative capacity of these machine learning algorithms is way above, is superior to all the other measures, which are so-called univariate markers, which we saw below. So even we see that CRSR is not a really trustable measure in prognostication, we calculated the sensitivity and specificity of CRSR score. And we could see that the heterogeneity is pretty big, but we couldn't conclude any reason for this, only that it's a small population. We tried to do a subgroup analysis, but we couldn't conclude anything else. But what we see is that the best sensitivity could be reached at a cutoff score of CRSR 6 point. It's a pretty low score since it goes from 0 to 23. So we can say that mostly the recovering patients mostly score higher than the CRSR score 6. This meta-analysis is the first that is directly comparing the two methods, EEG and CRSR score. We used a pretty rigorous methodology. We haven't missed any articles, we hope. There are some obvious limitations. The sample size is pretty small, and so there is a big heterogeneity. And we didn't have enough data to calculate the sensitivity and specificity results of the conductivity measures, which would be easier to transfer into clinical practice. And since we didn't have so many articles, we couldn't analyze the publication bias either. But we could achieve some nice conclusions, such as that EEG conductivity methods can be used with pretty good accuracy in prognostication of outcome in patients with the DOC. And the CRSR score should not be used for outcome prediction. What we think that can be a solution is the automated outcome prediction tools. So machine learning algorithms promise a good predictive ability. Some important implications for practice is that use of EEG besides clinical scales is highly recommended. And that what is really important is that the initial state when we first assess the patient and give a CRSR score, it cannot really determine their outcome. The implications for research is that more research is needed in the field. There is few articles with actually low quality, and also repetition of the already existing research is needed as well. The manuscript is already done. My supervisor is already reading the manuscript, and we hope that we can send it to internal review next week. My second topic is just a few words. It's about an EEG connectivity-based prediction system of outcome in aneurysmal subarachnoid hemorrhage patients. And we outdone ourselves with our first project, and we hope that we will do the same with the second one, so we could finish it this summer. Thank you very much for your attention.
Thank you very much for your nice talk. Any questions from the audience?
So it's about your first project. Are those studies focusing only on organic brain damage or functional brain damage as well? Okay. Only organic?
Yeah, only organic.
And is it, maybe it's just a question, possible to apply this for I don't know, maybe catatonic, schizophrenic patients, and because it's an interesting question, what is with those patients' consciousness level, and what are the outcomes then? So thank you.
Okay, thank you very much for the question. Yeah, it's only brain injured patients for different reasons, brain hemorrhages and so on, and we excluded all the patient population that is, for example, caused by, or these disorders of consciousness is caused by dementia or kind of Parkinson's disease and so on. The reason for that is probably because we are hoping for recovery in the brain damaged patient population, while as we think now or see now, there is no really hope for recovery in the dementia patient population. So that's why we excluded them from this research.
Thank you for the presentation. I would like to ask about the hypoxic brain injury patients. Can this connectivity measure be used for them, where there is no morphological issue?
Yes, definitely. There are a lot of studies, But here I was talking about only chronic or prolonged disorders of consciousness, and hypoxia is always treated as an acute disorder of consciousness, and after they pass this 1 month, they are treated as prolonged disorder of consciousness. And there are some studies from the acute disorders of consciousness, and it's very interesting, but they found the same markers that we have found in the prolonged state of disorders of consciousness.
So thank you for your presentation. I'm just wondering that when should we measure this, what you're talking about, and is one measurement enough? That's my next question. And what do you think, what do you know about the clinical situation? Are there hospitals where they use it? Because, for example, in my hospital, if I want to get a single EEG for my reanimated patient, it's a mess.
Yeah, I know. Yeah.
It's very difficult.
Yes, it is. So, going from question to question, the first is CRSR score, so the behavior assessment should be done every day for the patient, and then they calculate an average of the points. We couldn't do subgroup analysis, although it would have been interesting, of when was the measurement done and what is the outcome, so which is the perfect timing for doing the measurement. I couldn't answer for that question. But these patients are in coma for more than 1 month, so they are assessed regularly, like month by month, basically. These are not Hungarian articles, so they are from the Netherlands, from Belgium, from France, and from Germany, and also from China, yeah? And so the Hungarian situation is a bit different regarding use of electrophysiology, but we are working on making it more common, the usage of electrophysiology, even in the ICU or in, well, the use of EEG in the chronic department or on the chronic, coma department is a next step, but we will see.
Is there a difference between the EEG connectivity patterns in post-stroke patients and after subarachnoid hemorrhage?
You mean the stroke and the subarachnoid hemorrhage?
In the recovery.
In the recovery, yes. As we see, like clinically, there are a lot of ICU specialists here. Clinically, the subarachnoid hemorrhage patients recover faster, better, with better functional outcomes and so on than stroke patients. So we cannot really compare them, and we are aiming to find different biomarkers for the two different groups.